think it's information that is life-saving, and it's not ethical not to share this kind of information.
We said, look, we know dendritic cells can work naturally. What are we missing? And that's where we focused. And I'm just going to be super blunt and really simple here. We found it. And that's kind of what changed everything, is when we found it and realized we found it. We've gotten grants on this. We are doing everything we can to push this forward. It's a big find. If we can get a sample of it and we can get your dendritic cells, why can't we double load them with your tumor information? Not off the shelf. This isn't a drug. It's your tumor information, all of it. And then put those dendritic cells back in near draining lymph nodes, important lymph nodes, and get your immune system activated, going after the cancer in the fine-tuned, specific, powerful way that it can.
You inspire me to be the higher me. You're my inspiration to creation.
שלום לכולם וברוכים הבאים לפודקאסט השראה להבראה. Welcome to my podcast, Inspire to be Higher.
Deep within, let your dreams begin.
Hello, welcome back to the podcast. Today I'm honored to introduce to you Dr. Matthew Halpert, the founder, the CEO of Immunocine. He's an immunologist, a scientist, and I prefer that he tells you about this. I just want to add that this is something that is very important for me to bring to my audience, because I think it's information that is life-saving, and it's not ethical not to share this kind of information. So this episode is very important, and I hope many people use this information. So thank you, Dr. Halpert, for joining us.
Oh, thank you. Thank you for having me and for that introduction. I certainly agree with you that a lot of Immunocine is here because of ethics and kind of a moral obligation. So yeah, I'm happy to share all about the science and Immunocine and what we're seeing. Just wherever you'd like to start.
Just please share first about your experience as an immunologist, your research, and just your background to this.
Yeah, absolutely. So personally, I have a doctorate in immunology. After getting my doctorate, I spent about 10 years as an academic researcher in the Texas Medical Center, predominantly at Baylor College of Medicine, where I was just a scientist in the lab. That's what we were doing. And my research group, we were studying the immune system, how it works, what we're missing, what needs to be better. Publishing papers, getting grants, doing kind of the normal academic stuff when we made this really important discovery, which kind of changes everything. And that's how we as immunologists saw it. And so being here today is, after 15, 20 years of research, is a lot about passion and trying to get really good science into the clinic. So I know the crux is to dive into what was that discovery, right? What is this? So I'll try and be brief because it's like a 20-year story now, but it didn't start as for cancer. And to be honest with you, there's a lot of cancer clinics out there, and some of them do try to use the immune system to try and fight back. That's not how we view Immunocine. That's not how I view it. We view Immunocine as an immunology company that is trying to help cancer patients. We don't have 20 different a la carte offerings. We have one core technology that we are bringing to the marketplace, to the clinic, because of how much it can truly help patients. So when this started, we were focused on dendritic cells.
Right, because we speak about the immune system, but it's so many things. So
complex. Yeah. So the immune system is your defense system against everything. It protects you against viruses and bacteria and parasites and fungus and cancer. How does it do this? It isn't just one cell, right? It's a tapestry of all these different players, these different soldiers that have different abilities. Some go after this, some fight this really well. It's very impressive, very meticulously designed, and works together to keep you upright. And the cell that's in charge of all of that is the dendritic cell. Something has to be air traffic control. Something has to be the general of this massive army. And that's the dendritic cell, which was discovered in the 1970s by Dr. Ralph Steinman's group. And he eventually won a Nobel Prize for that. And, we know how important they are. We know they run the immune system. No one really debates that. The historical problem has been, okay, we know it's important in biology. How can we use it in the clinic? How can we use it to improve patients' lives and overcome different diseases? And truth be told, nothing's really worked so well in the past. It's got a long history of failures. And for anyone in your audience who has maybe gone to graduate school or medical school in the past 30 years, they may have learned that, dendritic cells they're important, but they can't be used. They can't be used clinically. We haven't figured it out. And so, that's where our group was. Our group worked with dendritic cells. And so you've got a couple things happening in the space. You have companies and money and immunologists that said, we can't use dendritic cells. Let's move down to the foot soldiers, these other immune cells, and try to figure out how we can power them up without the first cell, without the general. And this has led to some advancements in immunotherapy, checkpoint inhibitors, CAR T, absolutely, and they can be useful. Are they physiologic? Are they normal? No, they can't be. You skipped the dendritic cells, so obviously you have to accept there's just going to be some missing signals there. And you're probably not going to get a complete or optimal immune response. Doesn't mean they're not useful, just you have to accept that. You have other groups that also focus on how to empower the immune system, but not with checkpoint inhibitors, not pharma level, but more supplements, diet, peptides. And again, these can be useful. Are they powerful enough in and of themselves to overcome severe disease? Not yet. We haven't seen that. Not on the whole. Maybe some people will respond that way, but for the most part, no. Helpful, but not really going to do the trick. Then you've got really three different categories of groups that have stuck with dendritic cells because they are important. One group continues to do the same things that we've done for 30 years with no real advancement, and I don't understand that. I think they just think people aren't going to know, and it's true. I mean, my mom doesn't, she's not going to know, but it's not right. There's really no advancement there, or whatever they're claiming is some well, we do this is not really an advancement. It sounds nice. It sounds like big words, but it's not actually scientifically different. You have other groups that have said, well, dendritic cells, we can't get them to respond to, let's say, cancer, but we know they respond to the flu or polio or BCG or Coley's toxins or bacteria. So let's throw some of that stuff on. And maybe when the dendritic cells get activated against that, they'll also go after the cancer. Sometimes this helps some, but cancer's not tuberculosis. Cancer's not a bacteria. That doesn't actually make sense either, even if you do get some extra stimulation. And then you have a very small group of, masochists, almost people just signing up for torture, like my group, where we said, look, we're missing a mechanism. We're missing it. We know it can work. We know dendritic cells can work naturally. What are we missing? And that's where we focused. And I'm just going to be super blunt and really simple here. We found it. And that's kind of what changed everything, is when we found it and realized we found it, we had to back up and go, so that's been missing. So, said a lot of words. You want me to keep going and explain?
But so do you have a patent? Why doesn't everyone use it now? What's the...
Absolutely. We have a ton of patents, which does, in a way, prohibit others from doing this. So dendritic cells have two pathways to communicate. They have two pathways to take in information and then communicate to your foot soldiers. And we'll call them class 1, class 2, pathway 1, pathway 2. Again, that's immunology 101 stuff. That's not new. What no one has realized, still to this point, really not a lot of people have realized, is that within the cell, everyone just thought this was just done blindly. The dendritic cell just does it and communicates. It doesn't even know what it's really communicating, and that's false. It has a fail-safe mechanism, machinery inside the cell that prevents activation. And if you think about this, this makes a lot of sense. Deciding to eliminate cells in your body is a big decision. You don't really want that just happening so easily. If you're going to launch a nuclear missile, you watch a movie and you see the two keys have to be turned at the same time. There's a reason. You want that level of protection. Are we sure we want to do this? And so people have tried loading information, cancer lysate, cancer mRNA, cancer peptides, whatever, in one pathway or the other without the realization that when the dendritic cell sees the information in one pathway, it, before it does anything, looks to see if it also sees it in the other. And it's not good enough if they're just kind of close. It is precise. It is exact. If they're off even a single space, this does not activate. But when they overlap perfectly, everything changes. So if you're looking, I'm going to make up numbers here. If you're looking at an immune response, and using dendritic cells this way gives you an immune response of a 3. Again, I made it up. So 1 is baseline. We'll say 3 is a response. Well, what if we add this? Do we get it to a 3.5? Do we get the response to a 4? Oh my gosh, we did this and we got it to a 5. And this is what scientists do. It's all very small and discrete. And we've been looking for how to get it to a 6 or a 7. And when we double load, which is what we've called this, we get 9,000. Hold on. Who cares about a 5 or a 6 if it can do 9,000? We're playing with background noise is all we've been doing for years. Did anyone know the dendritic cell needs to be turned on with the target itself? It's not another drug. It's not another stimulation. It's the target itself and how it is loaded into the dendritic cell that allows it to activate. It's not one gene that changes. The entire transcriptome changes. It becomes this Th1 powerhouse cell, and all the responses we see are just kind of, I'm being hyperbolic, but they're off the chart. That's what we saw. And seeing that, it made perfect sense to us why dendritic cells have not worked in the clinic, why there have been, no one knew, you got to turn them on. You got to actually load them correctly. Mm-hmm. And so we're not hiding this. We have published this mechanism in various peer review scientific and medical journals. We've gotten grants on this. We are doing everything we can to push this forward. It's a big finding. Yes, we have filed IP, global IP on this as we've gone because we did recognize this could be pretty important. And we have fought to get this forward into the clinic correctly. Another little side note, right? A lot of great science is discovered in the lab, but by the time it makes it to the clinic, it is so bastardized that it doesn't work. We reached out to a group about licensing this to them, and they said, double loading is really hard. What if we just load with just one pathway? Then it won't work. Like, that's the whole thing. Like and they didn't care. They really didn't care. They really didn't care if it worked. They care if what their stock would do. It was very eye-opening, to be honest, because we weren't going to stick to the science. And so we did it ourselves. And so we've launched a company in the US. We have FDA clinical trials. We've been fast-tracked by the FDA twice because the data are impressive. We've won a Breakthrough in Cancer Award 2 years in a row. We are getting it down the path. We are getting towards our first FDA approvals. And to show people how powerful this can be, we did not pick easy cancers. We picked the toughest cancers we could think of, which did not make the business people happy, but they weren't around when we started. So, oh well. We picked glioblastoma, which is a very aggressive brain cancer. And more specifically, almost every patient enrolled had unmethylated MGMT promoter IDH wild type. What does that mean? It means that it's a subset of GBM where there isn't even really a standard of care. Median survival is about 7.5 months. Very few are still around at 14 months.
Yeah.
Without getting into all the specifics, I can tell you we have patients, multiple, who are now at 3 years or around or past 3 years who still have no evidence of disease. The trial isn't even designed to keep going because you don't design a trial for GBM that long. So did we cure everyone? No, that's not what I'm saying. Were we highly selective in who we took to make our stats look good? No.
No.
Again, the business people weren't there. We went the wrong way. We've learned all this. We didn't know. We actually took over half the patients that were in this trial would have been excluded from every other phase 1 GBM trial because they were in such poor shape before we were able to vaccinate that almost certainly it would hurt our stats. So a little trick with phase 1 trials is very often you cherry pick. You make it look good by being very selective with who you enroll, and we did not do that. We want clinicians to believe the data, and so we took even the toughest cases, where even if they had started relapsing before we were able to vaccinate, which you would think would hurt our numbers, and maybe it did. Maybe our numbers would be even better. Quite frankly, I don't know, but 3 shots of double-loaded dendritic cells, separated, 2 weeks each. That's it. That's all these patients had added on to their, after the resection and the standard, and many of them are still going. The median survival has been moved. We've seen similar things in pancreatic ductal adenocarcinoma. That trial is still open and going. We need more patients, but a lot of the patients are doing really well. The farthest out is now past 5 years. And we believe in this so much that our 3rd trial will likely be refractory melanoma, meaning melanoma patients who are no longer responding to treatment. Nothing I've told you about the discovery has anything to do with the type of cancer, the type of mutation, the hormone receptor expression. It's not about that. Someday we may learn that some mutations or some cancers respond better, but today, if we can get a sample of it and we can get your dendritic cells, why can't we double load them with your tumor information? Not off the shelf. This isn't a drug. It's your tumor information, all of it, and then put those dendritic cells back in near draining lymph nodes, important lymph nodes, and get your immune system activated, going after the cancer in the fine-tuned, specific, powerful way that it can. So that's all this is. It's biology. It's just overcoming immunological ignorance. The reason you're in this in the first place is your immune system didn't see the threat. We fixed that. And you have to do the trials. You have to get the stats. You have to get the regulatory approvals. But there's a lot of patients that don't have time for all that to happen. And the question is it ethical and reasonable to try and help them? Now, I mean, if you have breast cancer, we don't have a trial for that. If you have prostate cancer, we don't have a trial for that. So if you came to me and said, you're an immunologist, Dr. Halpert, I get it. I see the science. I'm even gonna do my standard of care. I just wouldn't it improve my odds if I got my immune system fixed physiologically to see this threat? And we would say, of course it would. Like, yeah, I mean, of course, that's all. I mean, in many ways, cancer is all about odds. What can we do to improve your odds that you truly overcome it? Yeah, of course, this is going to help improve those odds. It's not going to guarantee it. Can't do that, but it is going to improve the odds. So that's what we're trying to do, right? We're trying to improve the odds. We're trying to get people's immune systems on. And the question became, how do we legally and ethically, actually do this? And so we actually spent 3 years trying to meet with these various tourism groups that could maybe do this. They're treating cancer patients. And I'm absolutely not going to name names, but a lot of them do cut corners. For example, we make this in an ISO 7 certified clean room lab in Cancun, which is cGMP practicing on par with what we're doing in the trials. That's important. Most cancer clinics do not think that's important, or did not. We're not willing to make that investment. So it would get contaminated. It wouldn't be quality control. It wouldn't be checked. Can't do that. There's a lot of ways we could cut corners in the lab to make your vaccine. Like any chef with a restaurant, we could buy cheap ingredients, but what are you going to get? We don't want to do that. There's a lot of these places that don't have oncologists, or they, this is cancer. You need oncologists. So we made sure to enroll the right, doctors, the right medical team. We, a lot of these places do a la carte or kind of almost bait and switch pricing models. It's like they tell you it's one price, but then they get you there and here's 20 other things you really should add if you want this to work. And that didn't seem, I don't like that. I just don't like that model. And so we don't do that. So we ended up building Immunocine ourselves based on, okay, we have great science. We can really help a lot of patients. How do we do this? How do we do it legally, ethically, putting the patient first? What are the right ways to do this? So like I said, in many ways, Immunocine is continually almost a moral obligation. It's great science. It's great biology. It should be available. So yeah, what else can I answer? I know I talk a lot, but
no, it's fascinating, and there's so much to unpack here. But I want to start with: is it a monotherapy, or do you combine it with the standard of care? How do you usually do? How do you prefer to do it?
Yeah. So very case by case. And so as a note, Immunocine, we do a lot of work for free. We really do. We do not ask anyone to pay until they're approved, they're coming, and they're going to be in Cancun in about a week. Like, okay, please pay us. But for example, we will do complimentary, we'll do a medical review. It is required. We will do a medical review on every patient. We need to see their last oncology notes, their last scans, their last labs. We are looking for red flags. We are looking for, is this safe? That's kind of step one. We're not going to be medically reckless. Yes, there's 3 private hospitals in Cancun. We tend to work with Amerimed. They're internationally certified. It is first rate. Emergencies happen. It is cancer. We want to be ready. So you're not without medical infrastructure when you're with us. It's there, but we don't want that. This is outpatient, and so we're trying to make sure there's, as best we can, we don't see any potential catastrophes coming up. And if that passes, then we're looking for efficacy. Do we see anything that would tell us this is not going to be efficacious? This is probably not going to work. And then if not, we're not going to waste someone's time or money. We're just not. We do decline most. It's, it's not the easiest business model. It would be much easier to do what everyone else seems to do and says, just come on, we'll figure it out. But we do decline most. So in answer to your question, Immunocine, we offer this double-loaded dendritic cell platform to get your immune system fixed. We do have some other nuances we will add a little bit there. If appropriate, we can inject an intratumoral molecule to try to reheat it, make it more attackable. There are some drugs or supplements that might be beneficial in a particular case. There are times where we're going to recommend to a patient or require that they are on some sort of metronomic chemotherapy when they come to us, that we can then offer low dose capecitabine, for example, something like that. We need a therapeutic window. And this is always very hard sometimes to talk to patients about. But this is not magic. We are not going to snap our fingers and your cancer just gives up. If we approve you, it's going to still be a few weeks before we can get you to us. There's some lead time. And then when you get to Cancun, we've got to get your tumor sample. We've got to get your white blood cells. We've got to make your vaccine. That's another couple of weeks. And then when we administer the first round of dendritic cells, absolutely, your immune system is going to kick 90% of the time. It's going to, nothing's 100%, but most patients, their immune system will kick on right then. But at a maximum, no, it just started. So it's going to slowly ramp up, and that needs time. All that time, what's the cancer doing? Nothing? Just sitting there, giving up? No, it's cancer. And so if your oncologist has said, I think you've got 2 weeks left, then do not give us your money. Yeah. Like, this is, unfortunately, it's too late in the game for this to work. If you've got, so we're looking at that. And so now if you've still got, and again, I know it's a hard conversation because it's morbid, it's tough, but if you've still got 6 months a year, then we have time and we can try to work it in. But if you don't have that, then very often what our team will say is you do need to do standard of care, something to get the cancer's running away. It's 90% of the way down the racetrack. We're not, as it stands, we're not likely to catch it. You've got to bring it back. You've got to do something to punch it in the face, get it going backwards, make it stumble. Then we can come in, get this going, and try to clean it all up working together. And so patients don't always like that. There's some that's coming to us because they don't want to do chemo, and understand chemo is tough. And a lot of times the end result of chemo is still death, is still horrible. And patients, they say, why? Chemo's blunt. It's blind. It's poisonous. Yes, it will knock the cancer down. Who knows? Maybe it knocks it down 90%, but it's not going to finish the job. And then the cancer comes back, it's resistant, and you ultimately lose. So is it worth the side effects? And we want to reframe that a little bit for these patients. There is a better finish line now. If you can get the cancer knocked all the way back, and then we get your immune system educated and fighting, we have a shot at actual long-term remission. And so we need to look at it that way. So whereas, no, we're not going to say, come to Cancun and we're going to give you your next 4 months of chemotherapy, which you're getting that at home. Like, it would be more expensive. Like, it doesn't make any sense to come do that with us. But there are times where we will tell patients, you need to do your standard of care first, and then come to us. The only caveat I'll say is we do need tumor sample.
Right.
So
before you knock it out, you have to take the biopsy.
Yes.
In the right way that you need it.
Yes, correct. We cannot use tumor tissue that's got paraformaldehyde, formalin, paraffin. Most of the time, a biopsy is only for pathology. It's only to just look at it and see what it looks like. And the fixatives used for that degrade what we need to make our treatment. And the way we need it preserved is not mainstream. So most places don't naturally just do it that way. You have to ask them. So right, if you're on chemo or you're doing surgery, let's say you're doing surgery and the surgeon's like, oh, I'm going to get it, it's going to come back. I'm not going to get every cell, but I'm going to get everything we see. I'm going to throw it in the trash. Hold on. Before you do that, if you are thinking you want this vaccine, which would make sense and be great after a debulking surgery, save some of that tissue correctly. And so there are 2 ways to really do that. Either, 3 ways, depending on where you are. But one is do it at home and make sure your team preserves it in a way, flash freeze it, cryo preserve it. If they take some sample out and drop it in liquid nitrogen, we can use that. So they can flash freeze it or cryo preserve it. This is more commonly done at academic institutions, but it's doable, but the doctor has to be willing to do it. We've created a kit that we can send, and it's just we've made it pretty simple. Take some tissue out, put in the tubes of solution, put it at 4 degrees Celsius, ship it back to us. Full disclosure, no idea how this is going to work globally. This is a new pathway for us, so I don't know if it's going to be an issue or not, around the world, but we can find out. And then the third option is come to Cancun.
Yeah.
We still have to schedule it, but come to Cancun for a couple days. We will do the biopsy. We will get the material. We will analyze it to make sure we got good material. And then you go proceed with your surgery, whatever you're doing. Yeah. And we'll see you in a couple months. Now,
seems like the safest option.
In many ways, it is.
Yeah.
And you know what? Sometimes patients come and their tissue is super necrotic because of the chemo's working, and that's great. If we don't think we got a good sample, we're not going to just pretend we did. We'll tell you. And yeah, you lost some money because we still had to do all the biopsy and the analysis, but we're not going to take any more of your money or your time to make this vaccine that isn't likely to work. So we're honest. That's always a risk with any biopsy. Patients also need to know that doing a biopsy now is critical to preserving your opportunity, but it doesn't guarantee we'll treat you in the future. The future is unwritten. If we look at you in 4 months and let's just be super dark about it. You can't get out of bed. No, I mean, you might say, but I already came for the biopsy. I know. I mean, look, can you even get on a plane and get to Cancun? No, then we can't do this. And so we still are going to ethically do a new review to see if it's a good fit. So we're not going to put patients in a bad or dangerous spot. We just aren't. But if this can help, if you're approvable, yeah, I can't tell you anything better to add to your whole plan than this. You've got to get your immune system fixed.
Yeah. I want to refer to something. As a practitioner who comes from the metabolic approach to cancer, we always look for things that don't harm the system, the immune system, or else the whole person. And that's why at first, when I heard about your Immunocine, I was very excited. But you keep saying you call it vaccine, and today we know from everything that's going on that vaccines have adjuvants and they might have side effects. So I'm asking to clarify this. Is it a vaccine like others? What do you mean when you call it vaccine?
Yep. Yeah. The word vaccine has become very complex, convoluted, political to an immunologist. Vaccine, all a vaccine is anything that provides education to your immune system, period. It's not, that's it. Like, so anything else that's added or the different types that's not what I mean. So, right, the COVID vaccine is an mRNA vaccine, and there's polio vaccine. So, no, it's not like that at all. So
Do you use aluminum? Do you use anything?
no. There's no adjuvants, and it's not off the shelf. It's not, it's autologous. So let me tell you exactly what it is. It's your dendritic cells, your cancer. We go to the lab, we break the cancer down to its antigenic components in full, and then we double load your dendritic cells, get them working, QC them, and then we re-administer your dendritic cells to your lymph nodes. That's it. They're your cells that have been out of your body for all of 1 week and now are back in, but they're properly fixed and they're restored. That's it. Yes, if anyone's listening and all these, it's not that. And maybe we have to come up with a new term for it, but I don't know what to call it.
Right.
It's a personalized immunotherapy product, very different from any other quote unquote vaccine.
Right.
And so no, the side effects are not, there's none of that. The side effects are going to be, you now will likely have an immune response, which is good. What does that mean? Our number one side effect is fatigue. Your body's now using a lot of energy resources to propagate this immune response. Swollen lymph nodes. You may have low-grade fever. You may have muscle aches. You may have flu-like symptoms, which prognostically is great, and these are temporary and usually quite manageable. But other one-offs, you may have a headache that evening. You may have some nausea. You may have some chills. Change of appetite. These are you are sick, and so when we do this and you start having symptoms of being sick, that's not a bad thing. No. You kind of know right then, oh, it's working finally. I mean, where was this in the beginning? This should have happened forever ago, but it's happening now. The only dangerous side effect we've seen, and no, we do not see cytokine storm. We have not seen tumor lysis syndrome. We have not. Again, this is not a genetically engineered product, nor is it a drug. So we can't really overactivate. I mean, your body knows how to regulate dendritic cells in the lymphatic system. It does it all the time. The side effect or the effect we have to keep an eye on is tumor-associated swelling, pressure, and pain. And that's completely dependent on where the cancer is and the size of it. So if you're a prostate cancer patient with a lesion in your prostate, you're not going to feel that. You don't feel your prostate. It's squishy. It's going to fine. The immune cells will flood into that tumor. There will be some swelling and some local inflammation, which is what we want. you won't really notice. But let's say you've got a
in the head,
head could
the
be,
swelling, you will feel, and it's
which is why we do not we will treat brain cancer patients, but only after they've done resection and have cryopreserved tissue.
right.
If you have lesions in your brain, we're going to tell you, if we approve you, you've got to radiate them. You got to do something. You have to get rid of those because, right, swelling there could be dangerous, even though, yes, we have a neurosurgeon on board. What if you have a lesion in your breast? You'll probably feel the pressure, which again, not what do you think you're feeling? You're feeling the immune response, but okay, you'll feel pressure. But let's say there's a lesion in your rib or your spine. Well, there's not as much space there for the lesion to grow. That may hurt. And everyone's pain tolerance is very different. And if we look at the scan and we think a tumor's in a dangerous spot where if it swells, we could have spinal fracture or compression of nerves, we're going to tell you you need to do palliative radiation on that spot before we will do this treatment to mitigate that risk. If we're looking at colorectal cancer, could this cause obstruction, dangerous obstruction? And if yes, got to do something to mitigate that. Maybe it's a colostomy bag, a temporary colostomy bag, or maybe you need to debulk or something, because if we're not going to do something where then we've got to race you to the hospital because now we have a catastrophic event. So those are the things we have to look for as part of the review. Again, pain and pressure are not bad signs. They're actually great signs, but you still have to deal with it. You still have to deal with the reality of, and the good news is very often pinpoint radiation can be very helpful for painful spots. On the super end of it, it's just an immune response, which means run-of-the-mill steroids, dexamethasone, prednisone will turn it down. You have to weigh that. Do you want that? Sometimes you need it. And again, if your immune system is currently at a 0 and we fix it and it goes up to a 10, and a 10 is just too powerful, reducing it to a 5 doesn't mean it's not working. People need to keep that in mind, is you still have to live. You still have to deal with the symptoms as they are. Some people will they want severe pain, and I understand that, but you don't necessarily have to have that for this to work. So, but yeah, anyway, so those are kind of you asked kind of two questions about vaccine and about quote unquote side effects, which I always put in quotes because they're not really side effects. They're effects of a functioning immune response. So
yes, exactly. It's not like chemo, which destroys your immune response.
right. It's not doing that. And to as we've collaborated, and absolutely we work with a variety of practitioners in this space. I'll give a shout out to Dr. Naisha Winters. I'll give a shout out to Dr. Janet Mandel. Immunometabolism, very important. Yeah. Working together to reduce the fuel available to the cancer is going to be beneficial.
Yes.
It's like people will ask me, what do you, is that going to work? And it's define work. We're trying to put everything together. Do I think simply changing your diet is likely to lead to now you have no cancer? It's not likely. Right. It's happened, but it's not likely in and of itself. Right. But could that be helpful synergistically with a treatment like ours? Of course.
Yes.
I mean, absolutely. Right. So it does work together. We're still learning ourselves. We're scientists. We're still learning the best place to, where do we put this? When's the best time to initiate? But it does all work together, and people need to view it, especially if you've got a poor prognosis, a tough cancer or an advanced cancer. It's a fight. Yeah. I'll be honest, it's unlikely. It's not impossible, but it's unlikely that a single thing, right, including immunocine, is going to completely overcome the cancer. Have we had patients do this and get there? They have. Would I tell you that's my recommendation? No, I think you need to take it seriously. I think you need to look at all the tools available to you and put them together in a way that is going to really give you the best shot of a true complete win, not just a pretend win, but a complete win. Right. And so things like diet and immunometabolism and certain supplements and possibly standard of care, surgery, radiation, chemo, you need to look at all those things and then find the best time to get this physiological fix so that your body actually is aware of the problem and can get engaged. Because until you do that, you're literally your best weapon is twiddling its thumbs. And that just, again, to an immunologist, that doesn't make sense.
Right. So I so appreciate the fact that you are a scientist and you accept the fact that the metabolic state of the person will up his odds to, because you do refuse more than half of the patients that approach you, and I know I've referred a few, and it's
Yep.
been tough because they come at the wrong time. And so, but you do acknowledge the fact that being on the right diet and doing all the metabolic therapies is going to help eventually get to immunocine. And I appreciate it so much because we don't have this cooperation with many scientific establishments.
And no, I mean, and certainly I've talked about this with others. I mean, as you can imagine, with just who we are and what we're doing, we do get, again, a lot of inbounds where the patients are just very dysregulated. They're in very poor shape. Their ECOG is 4. I mean, if you're that dysregulated, you're less likely to have an activated immune response. Like, one, we're less likely to get that part going. Just
Exactly.
again, it's a little bit common sense, right? It's just, okay, the body is very messed up right now. It's very all over the place. It's very dysregulated. Are we really going to get the immune response going? Now, two, and this is, again, tough to sometimes hear, but let's say we do get it fixed, but you are just systemically inflamed. You're a mess.
Right.
Even as powerful as this is, if there's so much noise that the targeted response gets drowned out or distracted because, my gosh, there's inflammation everywhere, that makes it tougher. That makes it less likely to work. So ideally, we would get patients who have already been working on this. They do have their CRP and ESR are not through the roof. Their RDW is not over 19. Their IL-6 is not through the roof. Lymphocytes.
Their
Sometimes these
insulin
patients
is low, their glucose
uh,
level is
sometimes in an interesting, almost paradoxical way, these systemically inflamed patients, their lymphocytes are below 1. They're really low. That's not great either. So we want patients who are healthy. I mean, I know that that's tough to say in cancer, but try to be in a reasonable biological state. And we want the cancer to be either stable or minimal or on the backswing. If it's running away, where it's doubling every 5 minutes, it's not the right time to do immunosine, because ethically, it's just probably not going to be able to catch up. You've got to give it a chance to do that. But if you've got some available cancer that we can get a biopsy of, if you're in a biologically reasonable shape, you don't have impending organ failure, the cancer is somewhat controlled or on the backswing, then absolutely, I can't tell you one better thing to do than let us get your immune system fixed, educated from the top down, step one, and add that to what you're doing, because it's going to improve any and all possible outcomes. And again, have we genetically engineered you? Have we modified you? Have we removed your ability to do any other treatment? We haven't. If you still need to or want to do standard of care, do it. If you still want to do alternative therapies, do it. In many instances, we've actually added treatment options. So, for example, a lot of our patients will come and their tumors are PD-L1 negative, which makes sense. If you don't have an immune response fighting it, what is PD-L1? PD-L1 is a ligand on the surface of tumors designed to fight off an immune response. And the checkpoint inhibitors, specifically the PD-L1, PD-1 blockers, block that. A lot of patients are PD-L1 negative because, of course, they are. Why would the tumor waste energy on that if there's no immune response happening? But fast forward 4 months, 5 months, 6 months after the Immunocine treatment. And a lot of those patients, if they do a new biopsy, their tumors are now PD-L1 positive, which is proof right there. The tumor just told you your immune system is attacking it, and it's now decided it's got to put energy into trying to fight it off.
Yeah.
All of a sudden, those checkpoint inhibitors or any alternative, maybe high dose IV vitamin C, anything that's going to now reduce or inhibit PD-L1 is now a new viable option for the patient to consider. So we see that all the time, actually. It's really exciting if you think about it, because sometimes cancer patients run out of what to do next, and this can actually even increase your options down the road. So, but yes, we're very collaborative. We ideally want to work with patients, physicians, oncologists, practitioners. It's better. It's better for the patient, so we can coordinate and do everything we can to help people. And I will again make sure I say, so I want to be clear, right? This isn't magic. We do not cure everyone. We cannot control that or guarantee that. I mean, I'm not God. Everyone does have an expiration date, including us. And cancer's tough. And we just need our eyes open that it's just tough, and it fights dirty. Do we have a variety? Are our stats all improved? Do we have a variety of patients getting to disease-free status and living their lives? We do. And any oncologist that has looked at this data has actually basically just validated it. Some of them have jumped on our team because they can see that this is the future. They've said, yeah, we want to do better. We want to get it up to 100%, but what we've done is there's really no denying it. It does improve the potential outcomes. It just no one should come to us expecting a guarantee of magic, because that's not realistic.
Yeah. Can I ask just, what do you think, what's the hypothesis behind why does the immune system go to sleep, or like the dendritic cells are becoming this slowing?
Yeah, that's a good question, and I can only speculate as a scientist, because we don't know. I'm going to tell you now that the underlying reasons for cancer are still very, what has happened here? And of course, there's a ton of different things that lead to the cancer in the first place. It could be the food you eat. It could be the toxins. It could be UV. It could be an obvious carcinogen. It could be trauma. I mean, there are things, and those may continue to exist no matter what we do. But the other side of it is still, where is your immune system? Why is it not eliminating the cancer? So I said we have a very good objective response rate, right? About 90% of patients do respond correctly, and we'll have evidence. We even do our own immunological profiling of the patient before and during treatment. We can show them their immune system becoming educated and fighting. Why not 100%? I theorize that I think some cancer patients have cancer because the mutation, the defect, is in their dendritic cells. Like maybe their dendritic cells cannot be double loaded, and that is what allowed this ignorance to happen, that allowed the cancer to grow. Have I proven that? Have we proven that? No, we haven't. It's just a theory that I would be intrigued to study up on. Is some patients, or there's some people where that's the defect. The defect is in the dendritic cell, and that's why now the cancer exists. It's kind of that way.
Yeah.
You do, and there's just other issues. I mean, for some reason, the dendritic cell did not double load. It did not see this as a threat. That's almost a whole nother podcast, right? Like what immunologically happened here. All I can tell you is that if we take it to the lab and force feed it correctly, likely we fix it, because we're really making it happen. And then when we put those back in the body, they do what they're supposed to do. They do what they should have done on day one. It's late, but they're going to do it now. And for some patients, we're talking stage 4 patients who have been told there's no other option. We've seen it. And then their cancer's gone. And congratulations, please go live the rest of your life. You seem to be fine. Believe me, almost every time that's happened, I'm not going to say we're surprised, but we're not getting super easy cases. They're always tough. And so the number of times we have more patients that have reached NED or no evidence of disease as determined by their doctors, or have been stable for at least 2 years. We have more of those than patients that have passed away, which
Wow.
when you're dealing mostly with stage 4 cancer and we're 5 years in, that's kind of crazy actually,
Yeah.
to have more patients doing well than have passed. And um, we're going to keep working to make it better. We're continually pushing. What else can we do? What else can we add? What else can we
Yeah.
do to improve results? And so
I'll tell
I'm
you
excited.
one thing that you can do is wake up the dendritic cells to fight also other things, other like viruses, and we have so much going on. It's not
Oh,
cancer.
believe me, yeah. People have, I mean, one of my partners really wants us to go after EBV. And
Yes.
at the end of the day, this is actually a Th1 response is we're using it to fight cancer, and that is what you want, but technically it's an antiviral response. This is how your body eliminates viruses.
Right.
Um, we did some preliminary work on HIV. Like it's a targeting platform. So can we target cells that are infected with EBV? Yeah, I mean, almost certainly. Um, we're not a huge group. We're not Merck. We're not Pfizer. Like
Right.
it's gonna take a little time before we can get all that research in because we will not treat patients for things we have not done adequate research on to at least in good faith tell them we think this can really work. And so we're not there yet, but absolutely in the future. Yeah. I don't know. I mean, can we clean up long COVID? I mean, are there other things we can do? And
Right. Right.
yeah,
Wow.
maybe, probably. It's
Definitely.
just gonna, if anyone's listening and they want to support some research, happy to listen. Happy to consider that. It's just
Yes.
we're we're a little busy with patient load because we have just exploded in the past 18 months. I mean,
Yes.
just the number of inbound leads and patients and patient requests is just
Yes. And I have
through the roof.
to say that you really deal with the pressure load beautifully, and you answer everyone with patience, and you explain and really it's beautiful to watch as a practitioner who refers to you. I really appreciate everything. Your whole team is really
Thank you.
amazing.
Yeah, the team is amazing. We wouldn't do this if I couldn't trust, of course, the team, and they're very compassionate. Patients get a ton of time with doctors and scientists. Like it's not like I can't speak to everywhere in the world, but it's not how it is in the United States or Canada. You're not just shuffled around with uh, an admin person. Like it's really pretty doctor driven. So everyone cares. We
Yes.
become invested in every patient. When you're done with us in Cancun, you're not really done. We don't ghost patients. We have a whole follow-up team that's going to keep checking in with you and trying to advise and review data with you. And we're going to do everything we can within reason to help a cancer patient get to the desired finish line. It's important to us.
Yes, it's beautiful. But the fact that you're in Cancun, some people always are suspicious. Why
Mhm.
Mexico? Can
Yeah.
you just answer to that?
Yep. So maybe a little naive on my part. I did not realize when I started this that Mexico maybe had a less than great reputation. So there's a couple reasons. We know we can't do this in the United States at this time. And remember, we started this 5 years ago or even longer. Why not? There's really two reasons, or three reasons. One is um, we are doing the FDA trials. We are going for big time approvals. So that's a different effort, and we can't conflict with ourselves. We just can't. It's just not going to work for given the amount of investment and time and people there. We're not going to conflict with ourselves. Two, legal reasons. It just becomes more murky when you want to try and treat patients, and largely this is because this is my opinion, but a lot of people are very litigious. They're looking for someone to sue, and this is cancer. Things aren't always going to work, and so the FDA has cracked down on you really can't experiment on people. It just creates a mess. It's not regulated. All that stuff's kind of true. I agree with that. And then the third is cost. Um, this is going to be very expensive. The going rate for personalized cell therapy in the States is between $400,000 to $600,000, and if this is FDA approved for glioblastoma, great, insurance will cover it. Does that mean it's covered for prostate? No. It's going to be, you're going to have to pay that, and that's going to be really cost prohibitive. So, as I said, my goal that was not to how do we start this in Mexico, it was where can we do this? And I actually visited a lot of different places that were not just Mexico. The reason I settled in Cancun is I found this group of scientists with this ISO 7 certified lab and an expertise in autologous cell therapy. And I said, oh my gosh, this is insane. What is this doing here? And they said, well, we're one of the most certified labs in all of Mexico. We do autologous cell therapy. Our goal is to do everything right and the best way possible. And I said, we can work together. So we started that way because I found the lab and I trusted the scientific team. Because if you're not going to follow the science, what are you going to do? And then after we got the science on board is when we onboarded the oncologist, the interventional radiologist, and the doctors. And from our perspective, we have a protocol. We've gotten all our certifications. We are HIPAA compliant. We are doing all the right things. I didn't know until fast forward a couple of years that there's just all these other clinics in Mexico that are really not doing that, and they've created a variety of horror stories where patients go there and they get scammed or they get, it goes bad. Had I known that at the time, I don't know, maybe I would have looked elsewhere, but this is why we started in Cancun, was the scientific integrity and all the certifications and all the way we could do it right. And legally and ethically, this is physician-mediated compassionate use, and that's for stage 4 cancer patients, for autologous therapy, this is acceptable in Mexico, and that's important. We need to obey the law. We need to do those things. So that combination of things is why we started in Cancun. And I will tell you now, there's not a single patient we've had that has gone home and complained about the professionalism of the team, the cleanliness of it, the safety of the whole thing that they feel, or the cost. Basically, when you're finished, you go, yeah, that was a great experience, and it was well worth it. But I understand that before you do that, you hem and haw, and you don't know. And
Yes.
This is why we're trying to get the word out about how we do things is a little bit different than how other people might do things. So
Yes.
I'm a scientist. I did not go to grad school to learn how to market. So it's been a work in progress for sure. The fact that I'm not a business person, not a marketer, and Immunocine is growing as rapidly as it is a testament to the science, the team, and the way we're doing this, I think.
Yes, absolutely. I want to thank you so much. And maybe do you want to give a message of hope to someone who may be listening and is maybe overwhelmed with so much information, so much, what do you want to tell this person?
Yeah, no, I mean, I do maintain my opinion that cancer sucks. It does. And it's very exhausting. It's very scary. Patients are often overloaded with information from their doctors, from the internet. I mean, my gosh, the amount, and of course, not all that information is trustworthy. So what I would say is every patient has the right to say, I'm not going to fight this. I'm done. And absolutely, that is a decision some patients are going to make. But if you want to fight, there are options out there that can lead to disease remission, even if you are very advanced. And I'm going to tell you that because we've seen it. We have seen patients who are in hospice that we have been able to treat that now years out are great. We've seen it. So you have to keep that in mind, that it's not over till it's over. It may not be a straight line, but until it's over, you're here. And if you want to fight, fight. So, you can obviously get a lot of information on our site at immunocine.com. As I said, we're going to do a review for you for free, and we'll tell you what we think you kind of should do. Should you come right now? Should you get in better shape and then come? What have you? And if now's not the right time for Immunocine, it doesn't mean. We've had a number of patients who have been declined, fight, get in better shape, and then absolutely come on down, you're approved. And they get there. And if we can do all this and you get 50 more years of life, of good quality life, then this just becomes a distant chapter in the past. And you remember that time you had, and it might have sucked, but who cares? It's over with and you've moved on. And so keeping that framework in place is really important. You need a good support system. You need to do your due diligence, but there are weapons out there. There are opportunities. So only give up if you want to. Otherwise, there are resources. Keep fighting.
Yeah, amazing. Thank you so much. And for anyone listening, if you need more explanation in Hebrew, you are welcome to approach me through my site, and really we'll try together to get that window of opportunity to be able to maybe get cleared and get to Immunocine. Thank you,
Absolutely.
Dr. Matt. Thank you so much for the amazing work you do, and you are really inspiring us, the practitioners. We call this podcast "Inspire to Be Higher," and this is it.
Yeah.
Thank you.
No, thank you for having me on and for supporting us. And I look forward to continuing to collaborate with you on other patients in the future.
With pleasure. Thank you.
תודה שהייתם איתנו עד סוף הפרק. אני מקווה שמצאתם השראה בתוכן של היום. אם נהניתם, אני מבקשת שתשתפו את הפרק הזה אפילו רק עם בן אדם אחד. כך נוכל להפיץ יותר תקווה, ריפוי ושינוי חיובי בעולם. למידע נוסף אתם מוזמנים לבקר באתר שלי shiramed.com. תודה, וניפגש בפרק הבא.